You're listening to the UBC Medicine Learning Network.
Welcome everybody, you're listening to Metamorphosis, a podcast where we interview physicians from across BC and Canada with the aim of helping medical students navigate their medical careers. My name is Igor.
And my name is Ali. On today's episode, we are speaking with Dr. Kate Chipperfield, head of the Division of Heamtopathology at BC Children's Hospital. On top of all that, if you can believe it, she has a few more roles, but we'll leave it to her to introduce you to all of those.
Welcome to the show, Dr. Chipperfield. Thanks for joining us.
Thank you. Thanks very much.
As Ali mentioned, you have a number of different hats that you wear at work. So could you tell our listeners about some of the work that you do on a daily basis?
Sure. So I'm a hematopathologist, which means that I work in a clinical laboratory attached to the hospital here in BC Children's. And we also, within our laboratory, support Women's Hospital. So as a hematopathologist, I look at issues surrounding blood and bone marrow disorders. And so that's everything from malignant to benign disorders, disorders affecting bleeding and clotting, and hemoglobinopathies or red cell disorders, platelet disorders, you name it. If it's about the actual function of blood and bone marrow, then that's what we take care of. So in terms of other hats that I wear, though, you mentioned that I'm division head of hematology, so that's providing oversight to that division here within the laboratory, and some leadership to our small group of 4 full-time hematopathologists. And as well, I have a role in undergraduate medical education, a very small role in that I teach or lead one of the weeks for first year medicine in the bleeding disorders and hematologic malignancy week. And most recently I've taken on another role in postgraduate medical education and have become the program director of the hematopathology residency program through UBC. That's pretty much it.
And by pretty much it, you mean so many different things that you have to do on a daily basis.
There's a little bit of juggling for sure.
So when you first got into medical school, if you can think back to that time, what sort of things were you interested in at that time? Did you know that you were going to end up in something hematological or in pathology?
No. So pathology really didn't enter my mind at all as a career choice when I entered medicine. So I went to medical school straight out of my undergraduate years at University of Saskatchewan, and I got into medicine at U of S as well. And we had a class of 60, and you know, I enjoyed my undergraduate medical education very much. I was basically interested in any physiology of the human body, and I think though I was drawn somewhat to hematology because I'm kind of a visual person, and I really loved that you could very easily take a biopsy, so to speak, of blood and put it on a slide and look at it under a microscope and get a really good idea of what might be happening with a patient, not only with respect to primary disorders of the blood, but other things that are happening, you know, related to concurrent inflammation or you know, other issues that were going on. So I found that really fascinating, and within some few years, I was primarily interested in internal medicine, I think, after I finished my undergraduate years.
And what other specialties did you have on your radar at that time, along with internal medicine?
Yeah, so I was thinking about internal medicine, but I also was thinking about anesthesia as it relates to, you know, being the internist in the OR. And is kind of task-oriented and procedural, and that also really interested me. So I did do electives in both internal medicine and anesthesia to try and to make my decision.
And so were there any specific experiences that helped you decide and rule out one or the other?
Yeah. Well, I think in general I had mainly positive experiences in internal medicine, and, you know, enjoyed some of the complexity around figuring out what was going on with a particular patient. It was kind of like solving a mystery in terms of reaching a diagnosis. And I think looking back, that was quite telling that it was reaching the diagnosis that was the most interesting for me, and not so much the carrying out the treatment plan and follow-up, but we'll come back to that, I guess. With respect to anesthesia, I had done some local electives in Saskatoon and had been really enjoying myself, really loved the procedures, loved, that element of manual dexterity that's required. And then I went away to do an elective elsewhere and had not as great an experience. And for whatever reason that was, to be honest, it came down to the staff weren't as friendly to work with. And it was, therefore not that enjoyable to be spending a lot of sort of concentrated time sitting next to someone else. And I couldn't imagine a residency where I was going to be sitting with someone else in the room, sort of trapped, talking to them for, an 8-hour case, unless it was in a comfortable situation. So there was also one staff member who I was working with who herself had bad experiences in terms of having an injury that made, her ability to intubate, I think, less, she had less confidence in herself. And it was quite clear that was an uncomfortable situation. And sort of that made me think about those possibilities in my own career, and in the end I just decided that internal medicine was a better place for me.
So to you, fostering those connections with teammates and people who you work with is very important. Would you say it's very important as well during residency for students entering residency?
Yeah, I think it's difficult when you're entering residency because there are so many things to think about in terms of how to make that decision. And it's also really difficult because a lot of people making that decision are very young and haven't had a lot of life experiences. And that was certainly true of me. I was 23 actually when I finished medicine, 24, and was making that decision, and had never really worked beyond summer jobs outside of medicine. So knowing yourself and knowing what kind of person you are and what kind of situations you want to be in can be kind of difficult at that time. But as much as you can, thinking about how important is it to be, to really know a team, to really be surrounded by supportive team members, and what you want to be doing day to day. Whether you want to be seeing patients is one thing, but just knowing that what you're getting into, I guess, can be quite difficult when you're at that age and you have such limited experiences. So I would say going out and doing electives as much as possible, not only in your center, but in other centers might be helpful, because there may be a culture within your center that is either very positive in an area or somewhat negative, and you may find that experiencing that specialty in a different center can give you a better idea of what it's going to be like.
Right. And so, we hear a lot of mixed advice from senior students and obviously a number of physicians that we interview about how important it is to decide early on what specialty you're interested in. So based on your experience, do you think that it's better to just have an open mind or to decide early and just set forward on that path?
Yeah, well, I'm kind of a funny person to talk to about that, because I made a decision early on that I was going to do internal medicine, and of course that's not at all what I ended up doing. So I personally think it's having an open mind and trying to seek out an experience or an area of medicine that really you find rewarding and interesting, because you are going to be doing this many hours a day for a good number of years, and it has to be something that isn't just a paycheck, but it's something that you find rewarding. So personally, I would say keep an open mind and don't try and pigeonhole yourself into a particular area too soon. That's difficult because you also are told you should be doing research and electives in a particular area. But I think the best thing you can do for yourself is to not narrow yourself down too soon, but rather be open to different experiences and sort of reflect as much as you can. Do a lot of self-reflection in terms of how day-to-day experiences in a particular rotation or on a particular unit have made you feel. Did you find that it was rewarding. You came home feeling like really pumped. This was a great day. I enjoyed working with those people. I enjoyed seeing that kind of case mix. Or did you feel like, oh, this is kind of a negative situation? I didn't enjoy that aspect of it. My palms start sweating every time my pager goes off. Maybe that's not the area for you. So yeah, for me, I decided internal medicine was going to be it, and I was interested in hematology, and I did explore some other areas within internal medicine, but kind of kept an open mind, and then decided to pursue clinical hematology. And ultimately, when I was doing my clinical hematology subspecialty residency is when I realized that there was this whole other specialty related to hematology in hematopathology, and that I was actually enjoying my laboratory rotations more than I was enjoying my clinical rotations. Not that I didn't enjoy them as well, but it was a different thing, and I began to think, what would reward me as a person, and what would provide me with the kind of life that I wanted, and that's why I ended up pursuing hematopathology.
So were there any other subspecialties during your internal medicine residency that were kind of also on your short list?
Yeah, I considered both nephrology and endocrinology, also like very much, and not that every area of internal medicine to some extent is kind of a thinking specialty, but very organized, and sort of a lot of interesting and intricate feedback mechanisms, I guess, was what fascinated me. But when it came down to it, it was about numbers. It was about looking at numbers, creatinine and calcium and blood sugars. And what I really came back to in hematology was the fact that you could see blood under the microscope, and that visual aspect, and sort of the beauty of a normal bone marrow aspirate, and what it looked like and the organization of it was what really appealed to me. And so that's how I ended up pursuing hematology.
That's great.
Mm-hmm.
Do you have any other advice for people entering residency? Is there anything that you wish you had done to prepare for your own residency clinical practice?
No, I don't think so. It's really hard to look back and think, would you have done anything differently? Some people might say actually that my time in internal medicine was, quote, wasted, because I didn't actually end up doing internal medicine and hematology. I did actually all those exams. I, got my FRCPC in internal medicine and hematology before I, did my training and exams in Heampath. But ultimately, I think any general basis in clinical medicine will serve you well no matter where you go. So, even if you ended up doing something that's very much away from that in radiology or epidemiology or what have you, I think that will always serve you well, because you have a good grounding in the basics.
So then now, I guess, transitioning to the actual work that you do on a day-to-day basis, could you walk us through what an average day looks like, and all the different aspects of your day based on the different hats you wear?
Sure. So my day is sort of decided a little bit based on whether I'm on service or off service. So we have, as I mentioned, basically 4.5, close to 5 full-time hematopathologists here. So I work in a really supportive group setting in a hospital lab where we're fairly close together, and we work with the same group of technologists on the regular basis. So I get a lot of people interaction in my job. So service is when we're assigned to take care of some of the clinical responsibilities coming through the lab. So we divide it into 2 streams. The first one being primarily morphology based. So if there are blood films that a physician have requested a review on, then I will be spending my time reviewing that morphology and the case histories with my resident at the multi-head teaching microscope, sometimes with a medical student with us as well. So not only interpreting those studies, but also teaching at the same time. And any bone marrow aspirates and biopsies that have been requested, we'll be looking at those as well. So I may actually go out and perform marrow aspirates and biopsies on children with the help of anesthesia, doing sedation. So that's a great aspect of my job, where I get to still do a procedure, still go out and see patients, and also interact with the ward team, the nurses in the clinic, and sometimes the anesthesiologists and the nurses in the OR if the child has to go to the OR for that procedure. So that's sort of when you're on primary morphology service. It's a a busy day, and sometimes a fair number of phone calls and interruptions asking for urgent reviews, and then a fair amount of time divided between the microscope, the telephone, your computer, entering your comments and preparing your reports. And then the second line of service is pretty much everything else besides morphology. So it's kind of a grab bag of different issues that come up and different types of interpretations that you're doing. So any coagulation abnormalities, any hemoglobinopathy investigations for thalassemias or hemoglobin variants, we'll be interpreting and signing those out. Also, teaching with the resident how to interpret those, and transfusion medicine cases, and flow cytometry. So a lot of different things, and so it's sometimes a less busy service, but often a more in some ways a bit more of an exciting thing, because you constantly have to change what you're thinking about, and be changing from thinking about thrombotic disorders, bleeding disorders, to something completely different. Changing hats and thinking about a transfusion medicine case, and talking to an anesthesiologist who has a woman with a heavy postpartum hemorrhage happening. So that's a big part of what we do. And then when you're off service, meaning you don't have those clinical responsibilities, those are the weeks where you have to do your continuing medical education. You take some vacation out of those weeks. That's really what you would consider, I guess, protected time. But because I have a few different hats, I'm doing those administrative responsibilities during that time. So I'll be reviewing key quality indicators with my technologist team, looking at turnaround times, reviewing other quality indicators, meeting with them and trying to move forward any quality improvement initiatives that we're working on. That's also the time when I'm developing and working on teaching materials for both undergraduate and postgraduate education. And for example, I'm scheduled to give a talk for the NICU fellows next week, and so after I get off this call, I'm going to be working on that PowerPoint presentation and preparing that. And then again, recently having taken over for the program directorship, I'm basically responding to emails and trying to keep a handle on that situation as well. So and then of course there's the other academic activities in terms of research. So at the same time, trying to keep up with my collaborations with other my colleagues, and currently I'm participating in a couple of Flex student projects as well during this period. So it keeps you busy.
A lot to juggle.
Yeah, absolutely. Do you find that you have enough time to pursue activities outside of work and passions and things of that sort?
Well, I think that's one of the beautiful things about pathology and lab medicine, in that it is a lot more contained in a way. We do on-call, and actually our on-call is fairly busy, mainly because we have the issues of transfusion medicine that we handle, and those transfusion cases can happen anytime, day or night. But compared to being in-house and say an obstetrician, it's very different. Most of the things we can handle from home. So and when I'm not on call, basically my work day usually is like 8:30 to 5, sometimes 8 to 6, but almost never does it go beyond that, in part because most of the time an urgent diagnosis can wait, and if it's urgent, then you stay and you communicate with the clinical team and you take care of it. But a lot of the time things can be taken care of and shut down before 6, and I always just think to myself, is anyone going to be harmed if I go home at this point? And usually the answer is no, or obviously I don't go home. And the other one is, I'm tired. I'm maybe not thinking as well as I should. Should I be signing this out at this point, or should I wait and look at it again tomorrow morning and just make sure that my thinking is clear? And 90% of the time, that is actually the better option, is to wait and come back and look again and make sure you haven't missed anything.
That makes sense.
And is there something that in particular that made you want to switch to pediatric population at BC Children's?
No, I kind of just fell into that, and I think I've had a lot of luck in my career. But when I first came out of my residency, as I said, I did internal medicine and then clinical heme, and I did a total of it was 2 years of hematopathology before my exam. It actually turned out to be only 18 months because I had a baby in there, and I took a staff job in Vancouver because that's where the opportunity was, where I could do the mix of, at that point, trying to do clinical heme at the same time as hematopathology. And the job that I took ultimately was full-time at Vancouver General Hospital, and I ended up very quickly within about 6 months to a year of joining that team, not just being the medical director of the transfusion service there and doing hematopathology, but trying to, and having the directorship of transfusion medicine for all of Vancouver Coastal Health. And that was a big job for someone who was just out of residency, and it was a very heavy administrative role, and it was exciting, and I learned so much because I really had to be quite immersed in transfusion medicine through that time, and I developed some strong teaching interests by having that role and teaching transfusion medicine. So a lot of rewarding aspects of that job, but it also, to some extent was very demanding from an administrative perspective, and trying to push change in places where, they maybe didn't want to see change directed from a central, larger site like VGH. So after a time, I just found that it could be quite tiring, and I got a little bit burnt out, even though I still very much loved the people I was working with and the kind of work I was doing. And an opportunity came up to work at BC Children's, where, it's a single center, and you're working with somewhat of a smaller group. And I took that opportunity in part just because I needed a new challenge in my life, and it was time for a change after 10 years at one place. So I was lucky to have that opportunity to make a change, and it's turned out to be really great for me.
That's wonderful.
And did you find any barriers working in that role as a young new doctor? Did you find that you had any issues to sort of overcome during that time?
Yeah, for sure. I think you guys may find, and many people listening to your podcast may find, that as a young person coming out in residency, one of the major issues is looking young and being perceived as too young to be in that role. And I was a pretty young looking person, and I was young for that matter when I was just starting my residency. I was only in my mid-20s. So I had a lot of issues with that, and being a woman sometimes didn't help the matter either. So being an especially young looking woman was difficult, and the only thing I think that you can do in that situation is try to support others who are in the same situation, and holding yourself to a very high level of professionalism, and being very good at your job. And patients respected that, and your colleagues respect that, and sometimes speaking out and standing up for yourself is necessary too. But for the most part, just holding yourself to a very high level is what I found to be the best thing I could do. Then entering that kind of position at Vancouver General Hospital and having such a huge administrative role, come to me very quickly after also was difficult, again, because you're trying to achieve changes and make recommendations when you are what is perceived to be a young person without a lot of experience. Again, being a good listener, I think, and at least hearing out people who maybe are expressing a different opinion, and trying to have a really healthy professional dialogue. It's a lot like negotiation, where you have to realize you want to get something out of it and they want to get something out of it, and if you can just try to flex a little bit so that both of you get a little bit of what you want, things usually move in the right direction. yeah, so that's something to be aware of and that you're probably going to face as you enter your residency as well.
So are there any challenges now that, you know, you're not necessarily interacting with the patients as much? Do you find that there are any limitations to kind of your role as a result of that, the fact that you're not interacting with the patients?
You know, that I did for a long time miss patient interactions.
Mm-hmm.
On the other hand, there was a lot of things that I didn't enjoy as much about patient interactions. Generally, patients are lovely, and sometimes they're families that aren't so great.
Mm-hmm.
So I don't miss that aspect of clinical medicine. I still feel very connected to our patients, which may sound strange because generally they are they're a slide or a result and a name attached to a result. But we have a lot of interaction, particularly with our hematology oncology colleagues, and they're constantly coming down to the lab or calling us and discussing patient cases, asking for results and reviewing the morphology of the results with us. So that I do get exposed to the patient's story and their family history and how they're doing with their treatment a lot. So I consider myself as having that sort of the best of both worlds, where I hear about the clinical, I feel like I know the patient even though they don't know me. Mm-hmm. But I also get to go home at a decent time and have a good life outside of medicine that sometimes I think our clinical colleagues really have to suffer that consequence when they're have to be much more available to patient care at all hours that that suffers, whereas I don't have that issue.
Mm-hmm.
One thing I think about pathology that's really exciting is the other aspects that you don't think about. We have a lot of interaction with technologists, which is a whole nother group of health professionals that are extremely dedicated to their job, extremely dedicated to the patients, but are completely unsung heroes behind the scenes. So even though I don't get to work with nurses and respiratory therapists and physiotherapists out in the hospital, I'm working with a really dedicated group of very knowledgeable individuals. And I've formed great relationships with those people within the lab, so that it's not just the lonely pathologist sitting in their office not talking to anyone. We're constantly interacting as a group and collaborating to bring the best care that we can to our patients. And then the other aspect of pathology, especially clinical pathology like Heampath or MedMicro or clinical biochemistry, is that there's a lot of technology associated with our work. So, we're interacting with our technologists and helping them oversee the automated analyzers for CBC, for flow cytometry, for coagulation testing, and there's a lot of quality assurance and troubleshooting that goes into that. That can be quite interesting and exciting, and there's constant changes. Interacting with different software, digital microscopy. So there's a lot of aspects that might appeal to somebody who is more sort of tech savvy and interested in that type of thing.
And you mentioned earlier that one of the challenges was dealing sometimes with family or parents. Is that one of the things that you find is one of the major differences between adult and pediatric hematopathology? And are there other differences that you found working with those two groups?
Yeah, so I mean, really, it's the clinicians who take care of that situation. So, in internal medicine, you're dealing with an elderly person, and it's the absentee child who has been out of the city for 20 years and comes back and now wants to be involved in the care decisions for their parent, and that kind of dynamic that was more difficult. And in pediatrics, it's a family who's struggling with a serious illness in one of their children, which is obviously a devastating situation. But it's the clinicians who are having to deal with that, and as a pathologist, that's something that I'm quite protected from. So that's, I guess I have to say, that's the part that I don't miss.
Mm-hmm.
Yeah. Moving from from adult, medicine to pediatrics, I can just comment, even though I'm not a clinician, having spent time in both centers, pediatrics is, in babyhood, a lot more like people will say veterinary medicine, because you have to be able to read signs, and your patient can't really tell you in a history exactly what's going on. So as the child gets older, obviously that changes, but there's a lot of dynamics of social dynamics that overlay in pediatrics even more so than in adult medicine, even though, of course, in adulthood, socioeconomic status really plays a huge part in health, but in peds, even more so. And, the family situation, their situation at school, their interaction with their peers, there's all sorts of things that play into the health and development of a child. So, fascinating in its own way, but also, that has to be something you're interested in to really take on.
Mm-hmm. Now, obviously, a lot of our listeners are going to be from UBC, and we know you as the all-star lead for week 24. How did you find yourself as a lead for that week in Med 412?
Yeah, I think I, again, lucked out with that. So I had been invited to do a lecture in that week many years ago, and so had consistently given the introduction to transfusion medicine lecture in that week, and was also helping out in terms of the workshops where we have all those tutors who like to circulate both the anemia workshop in week 23 and then the coag and heme malignancy workshops in week 24, and that those weeks had been developed, I think, originally by Dr. Jason Ford, who actually previously was in this job at BC Children's as a hematopathologist.
Oh, okay.
And he actually left to practice outside of Canada, and it was taken over by another of my colleagues, Michelle Wong. And so, it went through several iterations of good teachers constantly trying to improve that week. And then when Michelle decided that she was going to move on to a different and add a different administrative role to her job, she needed to let something go and approached me about taking that over. And I was really excited to do that, in part because I was inheriting a really well planned out and thought out curriculum. And so there was, definitely a huge amount of hard work that went before me. But I think what everyone had brought to those weeks was first the collaboration between weeks 23 and 24, where now Leslie Zipchin, my colleague at VGH, a clinical hematologist, runs week 23. We collaborate together and try to make sure that we're speaking the same language to the students, so that we're using the same terminology, the same approach, sometimes reusing the same figures that you will have seen between week 23 and week 24. And making sure that all the lecturers across both weeks are teaching the same message in terms of a particular approach, either to anemia or bleeding or to abnormal CBC and query heme malignancy. So it's just a lot of organization, and I've really enjoyed the fact that I inherited a very well thought out curriculum from other teachers before me, and have just had the pleasure of trying to make minor tweaks and improve on it further.
Well, yeah,
That's
we
awesome.
as students definitely appreciated that nice flow between weeks 23 and 24, and how you guys collaborated. That was, much appreciated.
The easiest to study for the
Definitely,
midterm,
yeah.
definitely.
That's great. Yeah, I really enjoy distilling things down into a simple approach, because that's what worked for me as a medical student and has continued to work for me throughout my career, and that'll get you most of the way through everything. And it's layering on those small nuances and the detailed molecular knowledge much later. It's the basic approach that's going to get you there in the end.
So now you've taught, I guess, medical students and physicians at every level of training. What have you found to be some of the differences when you are teaching, undergrads versus postgrads?
Yeah, what I love about undergraduates is that you are still willing to ask questions, and willing to ask questions, at the distributed sites, in front of a few hundred of your colleagues, and still willing to say, I don't know. And the further you get on in your training and into your staff life, the more, I hate to say it, but a little bit of shame creeps in terms of not having that knowledge. And people are constantly, I think, trying to, show themselves in the best light. And that's understandable when you're thinking that you may end up applying for a job with this person that you're working with as a resident. But if you don't know something, asking or clarifying, I think is the best thing that you can do as a resident. And what I see is the difference between undergraduate learners and postgraduate is that there is an increasing reluctance to do that the longer you go in your training. And that's usually the most scary thing if we're concerned about anyone in a postgraduate situation, or even in a staff colleague situation, as if someone is unwilling to say, I don't know, or unwilling to ask for help, then that's a big red flag and something we're worried about.
Right. Now, is pathology and laboratory medicine, would you say that that's something that is shadowing friendly? If we have peers that, after the COVID situation is managed, would that be something that students are able to come in and experience?
Oh yeah, absolutely. Yeah, it's a great area for shadowing and for experiencing. I think we're always happy to entertain folks for a half day or a full day. Yeah.
Okay, that's awesome to hear.
Fantastic. Do you have a favorite part about teaching medical students or having medical students shadow you?
No, I mean, it's interesting sometimes to see your own job through someone else's eyes, and often for medical students, it's very eye-opening because not a lot of time or attention is focused on the laboratory when you are in medicine, or even in everyday life. There's been a million movies and television shows made about an emergency room, but no one makes a show about the laboratory.
Very true.
And it would be fascinating, let me tell you. But yeah, so it's usually a big surprise. People are surprised to see how many people work here, how many different areas and different technologies we're working with, the way things are set up, how things work behind the scenes, how much work and effort goes into something as simple as a CBC report. So I think that's what I enjoy the most, is even if someone's not going to be interested and ultimately pursue a career in the laboratory, I think it's nice for them to see what's happening down here. All the people who work to put out quality reports and quality blood products, if that's the case, thinking about transfusion medicine. And even if they don't pursue a career in lab medicine, that they have a better idea of what goes on down here, and that we're here to consult with, that we're just a phone call away in terms of asking a question about a particular result on your patient, or discussing a particular case. So that's what we're here for.
Well, now anytime someone says send it to the lab, I'm definitely going to have more appreciation for all that happens in that actual lab.
Yeah, absolutely. Yeah, and I think, the other thing about, for the listeners to think about is, we've talked strictly about hematopathology here as an area within what we call clinical pathology. But there are other areas that you can consider for a career within laboratory medicine. Anatomical pathology, which is pretty much surgical pathology, looking at solid tissue biopsies from any area of the body, any organ, also including forensic pathology and autopsy, or other areas of clinical pathology, including, like I mentioned, clinical biochemistry or medical microbiology, or even some genetic, molecular genetics or genome diagnostics. These are areas that you could also consider if there are other things besides blood that interest you more, although I can't imagine what would. Right.
And one thing we haven't touched on with you yet is some of the research that you're involved in. And I know that a lot of our peers are interested in research. So are there any interesting things that you're working on, or that are currently happening in the Vancouver area in your field of research that might be exciting to some of the listeners?
Yeah, so I must say that I feel like my academic career has been more concentrated in teaching, and research has not been something that I've been, in terms of basic science research that I've been involved in. But there is certainly that possibility, and I think pathology is one place where there's a unique connection to basic science and a basic laboratory that could allow you to combine that with your career. So for me, I've done mainly sort of clinical collaborations with colleagues. So clinically applied research, basically looking at sometimes knowledge translation and teaching of appropriate transfusion strategies to physicians. I've done some work in terms of looking at appropriate indications for red cell transfusion. Right now, the work I'm doing is with one of my clinical biochemistry colleagues, and we are looking at trying to establish the best way for recruiting normal people to provide blood samples for reference intervals to the laboratory, because in order to provide a reliable reference interval or biological reference range, we should be recruiting people who are similar to our patients but otherwise healthy. So we want people from all nationalities and cultures. We want women and men. For us here at BC Children's, it's uniquely difficult because what we want are pediatrics, and of course there's a real difficulty about getting blood samples from normal children who otherwise would not be getting a blood test done. So we're looking at that in terms of peripartum reference intervals for women who are in the third trimester and around the time of labor, and then also more recently trying to recruit healthy neonates with their mom to get an additional sample for some reference interval testing at the time when the baby is getting poked anyway for their newborn screening test. And so that's the study that we're working on most at this time. And unfortunately, we've had to pause with COVID that enrollment. But yeah, there's a lot of opportunity to get involved with research. I would say that any interested student could go to the website for the Center for Blood Research, which is based out of the Life Sciences Center at UBC. And there's just a ton of investigators through that center who would be looking for potentially some students to collaborate with them. Also the BC Children's Health Research Institute here on this campus and Vancouver Coastal Health Research Institute, all of those places would be good to check.
I think that's really cool because from what you describe, it seems like there is an opportunity for an intersection between advocacy for having, a representative reference range for all different types of people that live in our region and the actual clinical application of it. Very cool. Yeah.
So again, one of the things I've liked about working with, we've worked with several different medical students and residents is for the medical students, exposing them a little bit to the clinical laboratory at the same time where, they're also being exposed to the ethics of consent and approaching patients for consent. And it's been, I think, a really unique learning experience for them, but I have enjoyed, exposing them a bit to the clinical lab, which, some people may not have thought about doing an elective in.
Well, that's fantastic. And, I'm really hoping that this COVID situation clears up soon so you can continue doing that fantastic research and all the work that you do. Is there any final thoughts you have for our listeners or for us?
No, I think this is a really interesting time to be entering into medicine, and there's, it's a uniquely difficult time, but it's also really exciting. And I think basically over the past, several months of the COVID-19 experience, seeing the ability of the healthcare system to pull together and respond, and the ability of researchers to, take what can be a very long process of considering and planning a research question and developing a study, and how quickly they can condense it down and get something turned around and begin researching on something that we didn't even know about until before several months ago, has been really exciting and is kind of inspiring that things can be can be really positive coming out of a terrible situation.
That's wonderful. And that brings us to the end of our episode. And if there's one thing that we've learned from speaking with you, it's that you probably have many exciting things to get back to after we finish recording this episode. So we will let you do exactly that. Thank you so much for joining us, Dr. Chipperfield.
Thank you. Thanks very much.
Thanks for listening. For more episodes of Metamorphosis, look for us on Spotify, Apple Podcasts, or wherever you get your podcasts.
This episode was written, recorded, and edited with 100% adherence to social distancing guidelines. As usual, on behalf of the entire Metamorphosis team, we hope you are staying happy, healthy, and safe. See you next time, and remember to wash your hands.
This has been a presentation of the UBC Medicine Learning Network.